So, good morning, everybody, and welcome to this session on perioperative hemodynamic monitoring. My name is Michelle Chu, Professor in Anesthesia and Intensive Care at Karolinska Institute in Sweden.
My name is Bernd Saugel. I'm Professor of Anesthesiology and the Vice Chair of the Department of Anesthesiology at the University Medical Center in Hamburg in Germany.
Okay, so Bernd and I haven't exactly planned out this session because we wanted to basically answer your burning questions. So I'm going to start by asking you, every single one of you, to think of one burning question that you want answered before you leave us in 30 minutes. But I will start by asking you, Bernd, because you are the absolute expert in perioperative hemodynamic monitoring, and I can tell you that sometimes I call Bernd when I have a difficult patient. So what is your most basic level of hemodynamic monitoring of the high-risk surgical patient?
Yeah, that's a good question, of course, because all of you know that during the last decade or so, there was a lot of emphasis on blood pressure monitoring. So everybody was very much focused on figuring out that there is a relationship between intraoperative hypotension, low blood pressure during surgery, and postoperative organ injury. So the first question that I get in my clinical practice most of the times is, how do we measure blood pressure? Do we need an intra-arterial measurement? Do we need an arterial catheter? Or are we good with an oscillometric intermittent approach, like every 2.5 minutes or so? So the first question, if we talk about high-risk surgery, which could be, for example, major abdominal surgery, orthopedic surgery, that I get from my residents is, do we need an arterial catheter?
That is a difficult question, because if I ask my nurses and they're in a hurry in the morning, they're not too happy about me taking the time to put in an intra-arterial catheter. So let's say we have a 60-year-old man, ASA 3, diabetes, hypertension, no coronary artery disease, no heart failure, but plan for an open Whipple. Would you insert an intracatheter? Maybe we should ask our audience. How many of you would insert an intra-arterial catheter for blood pressure monitoring in this man? You would? Okay. So for those of you who wouldn't put in an intra-arterial catheter, would you like to tell us why? And there's no right and wrong, because we don't always put in, or we haven't always put in intra-arterial catheters. Would anyone like to say why, or what are your considerations? You don't have it? Don't believe in it? Your nurses are much better at looking at oscillum. Does anyone want to say? You put your hand up that you were going to put it. You would.
So,
okay.
Whipple procedure in a 60-year-old with some comorbidities. Who wouldn't insert an arterial catheter?
So everyone would,
no,
obviously.
There's one who wouldn't.
A Whipple's procedure, yeah.
Yeah, no, for a Whipple, definitely. I will
definitely. Okay. Yeah. So, Bernd, tell me why you would put in an intra-arterial catheter, because now the nurses are really on your back.
Yeah, so I would definitely want to have continuous blood pressure monitoring in this patient, and theoretically I could go for a non-invasive continuous system, but honestly, even in a healthcare system like ours, this is a difficult situation at the moment, because these systems are still very expensive. I know there are people from industry in the room, so I will repeat again that those systems would be very, for example, those finger cuff systems would be useful in those patients, because they provide continuous blood pressure monitoring, but we don't use them routinely at the moment. So in this patient, I would insert an arterial catheter. And my next question would be if I insert the arterial catheter before induction of general anesthesia or only after induction of general anesthesia. And this is something I discuss a lot during congresses, and it very much depends on the country. I speak in, some people in some countries are saying, are you simply crazy? You are torturing the patient? We just do that after induction of general anesthesia, and for others it's completely normal to insert the arterial catheter before induction. So I would be very interested, so if we now agree that there is an indication for intra-arterial monitoring, that we want to insert an arterial catheter, who would do that before induction of general anesthesia?
Okay, it's about a third, and the rest of you would insert the arterial catheter after induction. So let me ask you, Bernd, why pre-induction? Is post-induction hypertension such a big problem?
It is a problem. So first of all, perhaps we need to say that profound and prolonged hypotension is a problem. So I think that we kind of exaggerated a little bit in the last couple of years. So it's naturally nobody is probably harmed if you have an arterial pressure of 64 for, let's say, 20 seconds. But profound and prolonged hypotension is a problem. And we know that if you look at the complete intraoperative period, that about 1/3 of intraoperative hypotension occurs between induction of anesthesia and surgical incision. So 1/3 of intraoperative hypotension occurs before surgical incisions. That is hypotension that we as anesthesiologists cause with induction of general anesthesia. And this hypotension is associated with organ injury, specifically acute kidney injury. So I like to avoid post-induction hypotension, and we actually published a trial comparing continuous intra-arterial monitoring versus intermittent oscillometric monitoring during anesthetic induction, and you reduce the amount of hypotension substantially if you measure blood pressure continuously during induction. Because even if you think that you are very good, and even if you think that you are very experienced, it's very, very hard to avoid hypotension if you measure blood pressure only every 2 to 3 minutes. So I definitely would go for the pre-induction insertion of the arterial catheter, and this is even something that we recommend in our current German guidelines.
Okay, so that's important information. So we know that intraoperative hypertension is prognostically significant. We know that 1/3 of those cases will occur just after induction before you insert the before skin incision, and we also know that it is associated with poor outcomes. So that is the reason why we put in an intra-arterial catheter and we do it before induction. Does that sum it up?
Absolutely, perfect summary. There's a question over there.
But my question is now, if it was an inguinal hernia for the same patient, so why then you should put it up for inguinal hernia also?
Yeah, why would you insert an arterial catheter in that patient?
For the Whipple.
Yeah, for the Whipple, we agree. He needs an arterial catheter and he needs it before induction. For the hernia surgery, why would you then insert an arterial catheter at all?
No, but you argue that you should put it in before. So if that same patient was coming for an inguinal hernia, you would never put in, well, maybe.
I won't put an A-line in anyway. So it's if I don't have an indication for an A-line, I don't need to think whether I should do it before or after, because I don't do it. So this is an important distinction. I agree with you. So we need to be precise. So I say it again. If there is an indication for intra-arterial monitoring with an arterial catheter, then insert the arterial catheter before induction and not afterwards. If there is no indication for intra-arterial monitoring with an arterial catheter, don't put in an arterial catheter, neither before or after induction.
That's great, and thanks for clarifying that. Now, the second question that's kind of related to it is because you mentioned oscillometric, and we can take it with 2-minute intervals. It's pretty rough for the patients. Have any of you tried the oscillometric method every 2 minutes? It hurts. It actually hurts, right? So every 2 minutes for a patient, especially when a sedated patient. So is there any difference between the oscillometric method and the intra-arterial method in blood pressure?
Yes, there is. There is a difference in the measurement performance, in the accuracy and in the precision, and there is one or two very important things we need to consider. And the first one is that oscillometry by definition is intermittent. And you already mentioned there is you cannot cycle oscillometric measurements every 1 or 2 minutes for a couple of reasons. Two include that it can cause harm. So I'm dealing with a patient who has nerve injury after very long and high frequent surgery with high frequent oscillometric measurements, and the second one is the measurement per se kind of changes the value. So if you squeeze the brachial artery every minute for 2 or 3 hours, you will change the physiology of the artery, of the wall, and this will change. There are good experimental data on this. This will change the value you measure. So you cannot cycle the oscillometry every minute or so. So the first important thing is we want to have a continuous measurement, so it's intermittent oscillometry. And the second limitation of oscillometry is, and this is super important to know, that oscillometry overestimates low blood pressure values. So if your true intra-arterial blood pressure value is, let's say, 45 millimeters of mercury mean arterial pressure, and your oscillometric device tells you it's 60, then it is still 45. It's very nicely and consistently shown that oscillometry substantially overestimates low blood pressures. And for that reason, I disencourage you to do the following, which I often see in my institution. You insert an arterial catheter just before induction of anesthesia, you induce anesthesia, and then the intra-arterial measurement says, okay, mean arterial pressure is 40. And then you always have someone on the team who suggests, okay, let's double check this with oscillometry. I don't get it. Why should I double check an arterial catheter that I just inserted 30 seconds before? And the second one, if the oscillometric measurement then provides me a reassuring value of 60, I simply showed that oscillometry overestimates low blood pressures, and I didn't show that my arterial catheter didn't measure correctly.
Right. So that's an important point, and I saw many of you nodding, because this happens in my institution as well. Our blood pressure can't be that low. Let's check it with the cuff, and it's not that bad, right? So, but the opposite is also true. So at low blood pressures, it overestimates, but at high blood pressures, it underestimates. So in the patients that are most important to measure, the patients with hypotension and the patients with hypertension, that's when your oscillometric method becomes incredibly, not just ineffective, but it's not reliable.
And always to the disadvantage of the patient, because it always suggests that it's not as bad as it is.
Right. Any questions so far on oscillometry versus intra-arterial? All clear?
I would just like to underline the fact that if you use a size of the cuff which is not suitable for the patient, you will have false data. So if you will have a very obese patient in the morning and you'll put, doesn't matter, any cuff on that patient, you just will guess the arterial pressure.
That is absolutely correct. So there are many, many limitations to oscillometry that we often ignore, because it simply is a system that we use for like ever. Yeah. And therefore we have a big confidence that... I'm sorry, is it yours?
Oh, sorry.
Emergency in the OR. So it's...
Sorry.
No problem, Michelle. So this was the resident asking whether he or she should put in an A-line. Okay, so there are many, many limitations to oscillometry. One is that you absolutely need to choose the correct cuff size. Another one is that cardiac arrhythmias may be a problem, even if they are if you have bradycardia. And by the way, if you have a very, very morbidly obese patient with a large and conical upper arm, the best way to measure oscillometric blood pressure may be the forearm and not the leg, which often is used as a second choice. As the upper arm is not working, then patients use the lower leg, for example. There are good data from our group and from the US that the forearm is the second best option for oscillometric blood pressure measurements if the upper arm is not working.
That's a really, really good tip. And this is, I find it difficult to argue that because we're so used to putting it on the leg. That's the second go-to method. So forearm. So now that we've established that intraoperative hypotension does have prognostic meaning, we are inserting our intra-arterial catheter before induction to prevent post-induction hypotension and prolonged hypotension. The billion-dollar question is, does it make a difference?
I'm pretty sure that it makes a difference if you expose your patient to prolonged and profound hypotension. So we need to make a clear distinction here between, do we want to avoid hypotension, so do we want to avoid blood pressures that are substantially below a mean arterial pressure of 60, or do we want to do some kind of targeted blood pressure management that targets blood pressure of 85 or even higher? So to make a clear statement here, there is clear observational evidence that prolonged and profound hypotension is associated with organ injury, and we should avoid it. But there is no evidence whatsoever from randomized trials that you should generally keep mean arterial pressures at values that are substantially higher than 60 or 65. So this is a complicated and tricky situation at the moment, because there are a few trials, 2 major trials now, that show that generally keeping mean arterial pressures at higher levels like 80 or 85 does not improve outcomes. And people sometimes then conclude that blood pressure is not important or hypotension is not harmful, but that is not the point. We know that hypotension substantially lower than 60 to 65 is harmful, but at the moment we cannot recommend to then just keep it generally at higher levels to avoid it. So the clear recommendation in a couple of national and international statements at the moment is maintain intraoperative mean arterial pressure above 60, or some guidelines say 65. I don't think it's important, by the way, because we cannot measure blood pressure so exactly that we can say it's now 62 or 63 or 64. Just remember, don't allow mean arterial pressure to drop substantially below 60 for longer periods.
Right.
Do you agree?
Absolutely, and I think that's consistent with the upcoming European Society of Anesthesiology and Intensive Care guidelines to maintain that level of blood pressure. But let me ask you, what is your trigger level? What is the alarm level on your monitors perioperatively for your patients? What level do you have at your hospital?
Who's using an alarm level of 65?
60. Yeah, you're honest.
Who's using an alarm level of 70? 75? 60? Oh, really? You individualize your alarm threshold? Okay.
I work quite a lot on orthopedic surgery, and we have a lot of shoulders sitting position. Of course, we are trying to use the NIRS or something else to monitor what is most important. The quite a lot of fragile patients, so I really don't put trigger alarm on a definite level. Of course, a bit higher. If my nerves wants some numbers, okay, 75, 80, but it's not the point. The point is what happens in the skull. But if the patient is lying supine, well, why not 65? But the question is if we can individualize the blood pressure. Okay, is it a chronic heart disease? Is it septic patient? Do we have to mind the gut? A lot of questions. So it's not the best question. What level?
Well, actually, it's a really good question, and I'll tell you why. Because Bernd is conducting a study on exactly this, individualizing blood pressure levels perioperatively. Do you want to tell about the Improve Multi-study?
Yes. We only have 10 minutes left, and we should talk a little bit about cardiac output, but I will make it very short. So first point, very, very important point, of course, if you have performed surgery in a sitting position, you need to consider that there is a difference between the height of the pressure transducer that is usually at the level of the heart and the perfusion pressure in the brain. So this is important, of course. The second question is the individualized targets. The trial is done, so we performed a 1,300 patient trial, randomizing patient to an individualized approach where we defined the intraoperative target based on the nighttime blood pressure the patients normally have versus a one-size-fits-all 65 millimeters of mercury lower intervention threshold. Study is done, trial is done, results are not there yet. I don't know them yet because data are with the statisticians, but we will see. We will publish this in the next, let's say, half a year, and we will see. And yeah, to be able to speak a little bit about cardiac output, because I think we just noticed that everybody is very much focused on blood pressure and we often forget about other hemodynamic variables, and we only have 10 minutes left. My big question for you, Michelle, would be, would you measure cardiac output in this 60-year-old patient having Whipple surgery, in whom we now inserted an arterial catheter? So do you insert the catheter ready to go to the OR, or do you want to have a cardiac output monitor?
I would like to have a cardiac output monitor, and I'll tell you why. Because I know that flow and pressure can be decoupled. Flow is not always equal to pressure. So pressure is important for the perfusion of the organs. It's for example, with beach chest surgery, it's the mean arterial pressure minus whatever organ outflow pressure you have that will determine the perfusion pressure. But then flow, the delivery of oxygen, the delivery of nutrients, it's dependent on cardiac output. And for that reason, and especially in this man who has significant comorbidities that will have an important inflammatory response to surgery, I would definitely want a cardiac output monitor.
But Michelle, didn't you read our iPegasus trial and didn't you read the Optimize 2 trial? Cardiac output monitoring is not working. What do you say?
But it's the same as, it's the same as all the blood pressure studies. It's not to say that because the studies are negative that it is unimportant. I think there's a huge grey area, a lot of things that we still do not know. Now, Optimize 2, for example, it wasn't just cardiac output monitoring. It's cardiac output monitoring coupled to a very specific algorithm. So we don't know whether it's the algorithm, whether it's the patient, whether it's, the way we measure it, all those sorts of things. I would want to. I kind of ask myself sometimes, if I had been the patient, what would I like? And that's the answer that I'm giving to you. Obviously, you're all clinicians, you're all senior, you're all very familiar with these types of patients. At the end of the day, you need to be able to look at yourself in the mirror and ask yourselves, if I was on that operating theatre bed, would I want cardiac output monitoring? And for me, personally, the question is yes. And I think there's enough evidence to suggest that flow is also important to optimize.
I naturally agree. I just wanted to be provocative. But it's a troubling situation, isn't it? Because if you need to ask to your hospital management, for example, and tell them why you need 20 new cardiac output monitors for your ORs, they ask you what is the evidence for cardiac output monitoring, and it's very, very hard to pull up a single large, robust trial in perioperative medicine showing that cardiac output guided management actually improves outcomes.
And that is, of course, a huge problem because these systems are expensive. Just like, intraarterial catheters are also expensive, disposables are expensive. But I think we still need to focus on patient-important outcomes. What is important for the patient? And we did a large consensus not too long ago, and we asked the patient, even though, for example, cardiac biomarkers, there's absolutely no evidence that it improves outcomes in any way. Would you like to have it monitored? And all of them said yes, because if I had been lying on that operating table, I would want to know that you have all the bits of information to make an informed decision.
Yeah, I agree. Who of you would use cardiac output monitoring in the 60-year-old with comorbidities having Whipple surgery? Who would use cardiac output monitoring? The minority.
We have somebody who said definitely yes, and I want to know why.
Yes, so Jörg and I'm from Leipzig Heart Center. We don't do liver surgery, but a lot of comorbidities. But I would not focus on the cardiac output, because the reason of the cardiac output is to deliver oxygen to the patient. And I think that is a thing, even if you have the monitor on site, less people use that cardiac output to calculate the oxygen delivery. And that is at the end what helps the patient or what harms the patient, in my mind. And that is the reason why a lot of studies don't show the evidence, because they just focus on the number and not on the oxygen delivery. And that's, maybe we can do it better.
Absolutely, I think we both agree. So organs need both. They need perfusion pressure and they need oxygen. So oxygen delivery needs to be good. And I completely agree with you, of course, that you need to know cardiac output to understand hemodynamic instability or to get to the root cause of why a patient is hypotensive. So hypotension is not a disease, of course. Hypotension is just a symptom that can have numerous different causes. And if you want to know why a patient is hypotensive, you need to know more about cardiovascular dynamics, and this includes blood flow, oxygen delivery. And I think it's a fair statement to say that we would recommend to use cardiac output monitoring in this patient, but that we would explicitly not recommend to maximize stroke volume, just as in a couple of trials. So cardiac output is a very important variable to understand cardiovascular dynamics. I personally think that it's a very poor target variable, so you should not aim for achieving a certain target, and definitely you shouldn't aim for maximizing stroke volume or cardiac output all the time.
I'm so glad we agree, Bernd, because it's very not nice to not agree with you. So the reason why I have cardiac output monitoring in this patient also is to test the adequacy of cardiac output, right? And we can test it in several ways. PCO2 gap, for example, is one. I never look at the absolute value because that's basically useless to me. So the adequacy of cardiac output is more important than the actual number that I get on the screen. And the other thing about cardiac output is it allows me very easily to assess fluid responsiveness, whether or not you believe in that. Because, I don't want to be giving this patient an extra 500 bolus of Ringer's acetate or lactate if I don't have to. And that's the reason why I have these cardiac output monitors.
Yeah, I super much agree that cardiac output needs to be adequate. The problem is I don't really know what an adequate cardiac output is. It's super tricky because we don't really know what the metabolic demands are during surgery. So we know that under general anesthesia, even if you have major surgery, that your metabolic demands are about a quarter lower than if you are awake. So your energy expenditure in the awake state is, or during anesthesia, is a quarter lower than if you're awake. But there is some systemic inflammation, some surgical trauma, so I find it still very, very complicated to really estimate what an adequate cardiac output is. So we still need to look at surrogate variables, lactate, and so on and so on. But I think if we remember that it's important to know it, to understand cardiovascular dynamics, so to know cardiac output, and that we should not routinely aim for maximizing it, I think that's the best possible recommendation and evidence we probably have at the moment.
And, there is some evidence out there to show that maximizing cardiac output can actually be deleterious.
True.
Yeah. So for those of you who do cardiac output monitoring, how do you do it, and what do you aim for?
So we use a pulmonary artery catheter, and we just measure it at the baseline, and that is the value we want to achieve after cardiopulmonary bypass. So it's really an individualized strategy. It's not a fixed cardiac output, 2.4 liters per square meter, no. And we focus on the stroke volume index. And we want to have it at least at the lower normal level. If not, so if the patient comes in with a stroke volume index of 25, it's fine for us after the operation as well, if the mixed venous saturation is in a normal range, because that gives you an additional idea what the body needs.
Okay.
Yeah, I agree very much. And this is cardiac surgery, of course. So pulmonary artery catheters are still used also in my institution, and you see in other big institutions for cardiac surgery. I would say that it's important to say that we tell you that we do not generally recommend to use a pulmonary artery catheter during non-cardiac surgery. Otherwise, you would leave their session and would say, okay, they told us that we should measure cardiac output and pull a PA catheter in everyone. This is not the case. So there are less and non-invasive systems for non-cardiac surgery patients that are not as accurate as pulmonary artery thermodillusion, but are accurate enough to guide therapy in the perioperative period. Do you agree?
I completely agree, but I have to say they might not be accurate, but they're precise, so you can use it for tracking. So I think there's a really important distinction between accuracy and precision. So if I want to do a fluid responsiveness test, I wouldn't be relying on an intermittent method, whether it be pulmonary artery catheterization or transpulmonary thermodilution. But interestingly, because you mentioned SVO2, there's lactate and all that, what do you use to assess the adequacy of cardiac output?
Okay. I'm coming also for cardiovascular surgery, but I would make a distinction between cardiac patients and vascular patients, even when they are operated in the old techniques, open vascular surgery, and they are very bad, a lot of comorbidities. Of course, you don't put a Swan-Ganz catheter in each and every patient. Maybe in those with right ventricular dysfunction or pulmonary hypertension from the beginning. Maybe it's better to... Anyway, you don't have any opportunity to predict the fluid responsiveness using the pulmonary catheter. In the contrast, in a normal vascular patient, we use usually the peripheral methods, uncalibrated, for example, because we do not take into account the absolute values, but the tendency, the variation of the cardiac output. We can use also on the same method the PPV or the SVV. And of course, lactate, it's okay. Only one correction. Lactate will increase or decrease slow. So in these cases, an SCVO2 could be helpful to predict but even better than the SCVO2, you have the pulmonary capillary refill time in some patients. If they are not very cold and they are not very hypotensive, you still can use the capillary refill time.
I agree, but I would say that the capillary refill time is very valuable in the ICU. If you have poor capillary refill time in the OR, something really went wrong. Yeah. So we are on at the end of the session. There would be many more questions that we could discuss, but many of you and we need to run to the next session. So thank you very much for the interactive discussion. Thank you very much for the case that you suggested, and enjoy the rest of the Congress. Thank you. Yeah.